Hi, my name is Amanda Sills, and now we're going to look at respiratory. We have some lovely pictures on your screen, and no, that's not an ear, that's a lung. And if you'll notice something about these lovely pictures, we have the two linings drawn incorrectly. Normally, those two linings are not supposed to be separated, right? Right. They're supposed to be slam dunked together and vacuum packed. By vacuum packed, what do I mean? There's no air in there. There's no air in there. At least there's not supposed to be anything extra in the pleural space, but things can happen like a motor vehicle accident, and then air can get in there, blood, or exudate. Now, when stuff gets into the pleural space and accumulates, what's that doing to the lung? It's collapsing it. It's collapsing it. So that's why the doctor's going to have to do some procedures to remove foreign stuff from the pleural space. So let's talk about some chest procedures. We have a thoracentesis. Now pre-procedure, you're going to want to get a chest x-ray. Take a chest x-ray and get those baseline vital signs. Chest x-ray and baseline vital signs. Now, positioning during the procedure. One position is have the client sit on the edge of the bed and lean over the bedside table. Just make sure you lock the bedside table. Another position they might do is you can have them sit in a chair, but turn the chair backwards and have them prop up over the back of the chair. Now, if you're talking about a multi-trauma victim and the client can't sit up, then the client will lie on the unaffected side with the head of the bed at 45 degrees. In other words, good lung is down. They are on the unaffected side. Now let's look at other things during the procedure. The client must remain very still, no coughing, no deep breaths, because we're going into the pleural space with a needle. You don't want to accidentally puncture the lung. Now let's make sure we all understand this. The blood, fluid, exudate, or whatever is being removed from the pleural space. And as that fluid is removed, the lung should do what? Re-expand. Yes, we're looking for re-expansion. But since we're removing fluid, the client is at risk for fluid volume deficit. There you go. Fluid volume deficit. Anytime we're removing fluid, they're at risk for fluid volume deficit, right? Right. Therefore, what do you need to be checking? Vital signs. Check those vital signs, because in a fluid volume deficit, what's going to happen to that blood pressure? It's going to go down because less volume, less pressure. Now, what's going to happen to the pulse in fluid volume deficit? Pulse is going to go up. Yes, so blood pressure is going to go down, pulse is going to go up. That's why you have to take those baseline vital signs to begin with. Now let's look at post-procedure. Get another chest x-ray. Okay, we want to see what the lung is doing. Has it re-expanded? How much more fluid is still in there? Now, when they do a thoracentesis, they have some options. It can be a one-time deal. They can pull the tube or needle completely out of the pleural space, and then we put an occlusive dressing over the site. Or they can leave a little line in there, a little valve. We call that a Heimlich valve. That valve's used only if the lung has not re-expanded and little or no drainage is expected. It's just a little thing that actually they can walk around with. It's a one-way valve that lets air out but can't handle a lot of drainage. If the client has a lot of fluid or air in the pleural space, then they're going to need an extended period of time to get all of that out of there. So that's when the physician will go ahead and place chest tubes. Now let's look at our book at chest tubes. First, look under chest tube insertion. What has happened that the client needs a chest tube? The lung has collapsed. Now, this collapsed lung may have occurred as a result of thoracic surgery or lung cancer, abscess, or tumors. Can also be due to spontaneous pneumothorax or trauma, such as a motor vehicle crash or a fall from a high place. Whatever the reason, the principles are the same. If the chest tube is placed in the upper anterior chest, second intercostal space, then this is for the removal of air. That's for the removal of air. If the chest tube is placed laterally in the lower chest, 8th or 9th intercostal space, then it is for drainage. Why? Because air rises and drainage settles. Now, sometimes the physician just inserts it mid-axillary and uses one tube for air and drainage. This position is just more comfortable for most clients than a tube coming out of the front of the chest. Also, anterior tubes require you to cut through the pectoral muscles, and that will require prolonged healing. So that's not always used. But if you see an anterior chest tube, I don't want you to freak out, okay? The chest tube placement is for removal of air, and it looks sort of strange. Now, can the client have both? Yes, they're Y connected together and attached to the closed chest drainage unit, or CDU. So picture it. The chest tube is sutured to the chest wall, and a Vaseline or airtight dressing is applied around the chest tube exit site, and the chest tube is attached to a closed chest drainage unit, or CDU. There are lots of different brand names for chest drainage systems, but Atrium, Plurivac are some common ones you will see. Now, you don't have to know the brand names for NCLEX purposes, but when the physician writes the order, they will typically use the brand name, so just familiarize yourself with the different brands. What you do have to know is the purpose of the system. So, what is the purpose of the CDU? Read with me. It is to restore vacuum pressure in the pleural space. The CDU does this by removing all air and fluid in a closed one-way system until the source of the air or fluid can be corrected. You see, we have to get that pleural space slam dunk together again, okay? And that's what the CDU will do. It will restore the vacuum pressure, remove the air and fluid, and prevent further collapsing until that lung is well healed. It does this by using a one-way system. Air and fluid will not go back in. We're going to talk more about that in just a second. So let's see how this works. Look on your student page with me. You see, this is a single box, but it has 3 connected chambers. And the first chamber is the drainage collection chamber. The chest tube connects to a 6-foot connection tube that leads to a drainage collection chamber. This 6-foot length gives the client flexibility to move around and turn in bed. It makes sense because drainage needs to deposit first, so that's why the drainage chamber is the first chamber. You can actually write the date and time on the CDU to record the output as well as document in the client's records. Now, what do you do if the chamber becomes filled up, if it fills up? You get a new CDU, get a new one. Typically, you don't have to worry about that because the chamber holds about 2,000 milliliters, so you rarely empty or change the CDU, but you do not want this to overfill, okay, because it will block the water seal chamber and cause a tension pneumothorax. So if it's almost full, the best thing to do, just get a new CDU. The second chamber is the water seal chamber. What is the purpose of the water seal? To promote one-way flow. Yes, we want one-way flow out of the pleural space, thereby preventing air from moving back up the system and into the pleural space. Now notice something. I said one way. We want fluid or air to come out. You never want anything going back in. That defeats the whole purpose. Now as we look at the box, we see the drainage goes into the collection chamber, or the first compartment. So where does the air go? That's right. It's vented out. Yes, the air is vented to the second compartment, which is the water seal chamber, and it bubbles up through the water. You see, the drainage chamber and the water seal chamber are connected by a straw-like channel that allows drainage to remain in the first chamber and air to go down into the water of the second chamber. This water seal chamber contains 2 centimeters of water, which acts as a one-way valve. In other words, we're preventing backflow. Let me put this in simple terms. If you have a glass of water with a drinking straw in the glass, you can blow all the air you want through the straw and it just bubbles out the top of the water, right? Right. As long as that straw is underwater, then no air can go back into that straw. Same principle here in this chamber. Air can bubble out, but it can't go back into the lung. That's what we want. We want one-way flow. Now you may see bubbling in this chamber when the client coughs, sneezes, or exhales. You might see that bubbling. This is intermittent bubbling and it's normal. You also see a slight rise and fall in the water seal tube as the client breathes. This fluctuation is called tidling, and this is normal. Now, if the tidling stops, that usually means that the lung has re-expanded, and we'll cover that in a minute. So the air exits the water seal chamber. It's going to enter the third chamber. We call that the suction control chamber. This allows any air to be vented out the system from the air vent above this third chamber. We don't want the air to build up in the CDU, so the air vent allows this air to escape. Again, that third chamber is the suction control chamber. If the client needs suction to get that air and fluid out, this chamber controls the amount of pressure that is applied. It's called the suction regulator. Sterile water will be placed in this chamber up to the 20 centimeter line. 20 is the usual amount of prescribed pressure. This chamber has an air vent at the top to release any excess pressure. This means that 20 centimeters of suction pressure is being placed on the lung no matter how high you turn the wall suction on. This prevents too much negative pressure buildup in the pleural space. This is a safety thing. Turn on the vacuum wall suction until you have slow, gentle, continuous bubbling in this chamber. So you want slow, gentle, continuous bubbling. If you turn the vacuum wall suction too high, you will have vigorous bubbling and cause the water in the chamber to evaporate quickly. The pressure is not controlled at the wall, but by the water level in the suction control chamber. So watch the water level for evaporation. Make sure you keep it at that 20 centimeter line or whatever number the physician prescribes. You're going to add water to this chamber as needed to maintain that prescribed level. Now, if a dry suction system is used, water is not used to regulate the pressure, therefore there won't be any bubbling. A dial is used to set the desired negative pressure. Once again, increasing the vacuum wall suction will not increase the pressure. You know, this week you've heard us use the words client, physician, nurse clinician, and prescription a lot. Well, these are NCLEX words. These are the nouns you will see on NCLEX, so we want you to get used to them. Now, management of the client with the drainage system. Assessment first. We're going to assess the dressing around the chest tube where it enters the chest. The dressing must be kept tight and intact. You want that dressing tight and intact. Most likely you will just reinforce this dressing here because you don't want to accidentally pull out the chest tube when you're removing the dressing. So usually we just reinforce. We're going to listen for breath sounds on both sides, and a good rule of thumb is to compare the good lung to the bad lung, right? Yes. Monitor pulse oximetry to see the effectiveness of breathing. We're going to report anything less than 90%. Report anything less than 90%. We're going to record the chest drainage every hour for the first 24 hours and then every 8 hours after that. Every 8 hours after that. Inform the physician if there is 100 milliliters of drainage or more in 1 hour. 100 milliliters of drainage or more, and you need to notify the physician. Also, if you notice a change in color, like from yellow to bright red or from brown to bright red, you know you're in trouble, right? Right, so you need to contact the physician as well. Don't forget to have your client deep breathe, cough, and use that incentive spirometer as well, because what are we worried about here? We're worried about atelectasis and pneumonia. You're going to also want to watch for fever, elevated white blood cells, and drainage because you could get an infection at that insertion site. They're prone to infection at the insertion site. Now, what are you watching the daily chest x-rays for? What are we hoping that lung does? Re-expands. Yeah, we want re-expansion. Now, let's look at maintaining that CDU, that closed drainage system. Keep the system below the level of the chest. Why is it important to keep the system below the level of the chest? Because if you lift it too high, what's going to happen? That fluid, that drainage, will go back into the client's pleural space. Again, you don't want anything going back in. We want gravity drainage out, don't we? Yes, we want gravity drainage. Now, nurses know that, but what about the transport person that takes your client downstairs? They roll them over on the stretcher and they say, "Here, buddy, hold your box while we go down there." No, you're not going to go down the hall holding your chest drainage unit on your stomach, but you'll see things like that, so you have to watch out for that. So let's say you have a management and delegation question where you as the nurse are asked to delegate this transport. What would you say? This client will require ongoing assessment as they are transported to another unit. You as the nurse are the only staff person who can not only assess the problems but also fix the problems that can occur during transport. So do not delegate this task. You see, it takes an understanding of medical and surgical procedures to determine how to delegate. That's why you need to know your core content first without a doubt or without hesitation. We're going to keep those chest tubes straight and free of kinks and dependent loops. Sounds like a urinary catheter system, doesn't it? Yes, very similar gravity drainage. Tape all connections. We don't want it to become disconnected. It must be a closed system. Has to be a closed system. Some hospitals even use those tie-down fasteners. We're going to monitor the water level in the system. The water seal and suction control chambers must be kept at prescribed levels. Hey y'all, some companies put dye tablets in the water seal chamber and the suction control chamber to turn the water blue. So when you're setting up the system, don't be surprised if you see these tablets. This makes these chambers easy to see against the rest of the system, and it helps you to pick up on problems more easily. So it's a really good idea. Now, do you want to see fluctuation in the water seal chamber? Yes, you want fluctuation with respiration. When you see fluctuation with respiration, that means you have a good connection. That's all it means. It's a good thing to see. Fluctuation of the water level in the water seal chamber indicates the system is patent. Fluctuation will stop when the lung has re-expanded, if the chest tube is obstructed or kinked, or if there's a dependent loop in the system. If the client is attached to suction, then the titling may be obscured or hard to assess. Now let's look at some troubleshooting. What do you do if the tubing becomes disconnected? Let's say you're turning your client in bed and you don't have enough slack in the tubing. Could the connector between the chest tube and the client come apart? Look at your picture. Yes, it could come apart at the weak connection site. If it comes apart at that connection site, the air from out here can do what? Go in. So the most perfect answer would be to have another sterile connector sitting at the bedside. So you could have a fresh sterile connector right there and just hook it back up. But if that's not there as an option, what should you do? Reconnect as fast as you can. You remember the 5-second rule from grade school? Yes, you pick that thing up off the floor and you reconnect as soon as possible, because the whole time, what is rushing into your client? Air, and that air is doing what to the lung? Collapsing it. What if the CDU falls over and the water leaks out all over to the floor, or maybe it shifts from the water seal chamber to the drainage chamber? What do? You do whatever you have to do to reestablish that water seal. You set that CDU upright, check all the chambers, fill the water seal chamber to the prescribed amount, which is 2 centimeters of water, and again, make sure it's sterile water. Check the prescribed amount that should be there and replace it. You will also have the client deep breathe and cough in case any air went into the pleural space. If I do not have water in the water seal chamber, then air from out here can do what? Go back into the pleural space and collapse my lung. So you've got to have water in the water seal chamber of the CDU. As long as we've got water in there, air cannot dive through the air vent, go underwater, and go up, right? It can't happen. So let's say you're lowering the bed, and you lower the bed onto the CDU, breaks the CDU, and the water pours out all over the floor. What are you going to do? Well, we've already said that as long as you do not have a water seal, air from out here is going to do what? Go into the pleural space. So that's why when you've got chest tubes, you're supposed to keep a bottle of sterile, normal saline at the bedside. And what you'll do is you'll take that tubing and you'll stick the tube into the sterile, normal saline. Now make sure it's below the level of the chest, of course. You do whatever you have to do to reestablish the water seal. That's the key. So let's say somebody got your sterile, normal saline that you had sitting at the bedside. So now the perfect answer isn't there. What are you going to do? Grab a cup of water maybe that's sitting by the bedside. Grab that ice pitcher full of water that you brought in that morning. You grab that, you put it on the floor, and you stick that tubing into the water to reestablish that water seal. Then, of course, you're going to get on the call light, tell somebody to bring you another CDU. Let's say you're changing the dressing around the chest tube insertion site, and you're pulling it off one layer at a time, and then you get to the last layer and it's stuck. Okay, so you pull on it, and when you do, that tubing just comes right on out, and now you're looking at a big hole. What do? Oh my goodness, reinsert? No. You just became a pulmonologist if you do that. So what are you going to do? Well, the perfect answer is you're going to take sterile Vaseline gauze and tape down how many sides? 3 sides. Okay, but what if that's not an option? Because we don't walk around with sterile Vaseline gauze in our pocket, do we? No. So what do? What should you have put on before you went into the client's room? Gloves. So you slap your hand over that site, get on the call light, tell somebody to bring you some sterile Vaseline gauze, because you don't want any air going into that pleural space. And every time that client takes a breath, they're going to pull air into the pleural space. So you put your hand over that site until you can get some Vaseline gauze. Now, before we go on, I do want to get this bubbling thing straight, okay? Because sometimes bubbling is normal, and sometimes it means there's a problem. So let's look at when bubbling is normal. If the chest tube is connected to suction, then gentle, continuous bubbling is expected in the suction control chamber. That's normal. If the client with a pneumothorax is coughing, sneezing, or just taking a deep breath and exhaling, you may see intermittent bubbling in the water seal chamber. The client is just forcing air out of the pleural space, so that's normal. As long as there's intermittent bubbling, the client needs the chest tube because they're still leaking air out of the pleural space. So when is bubbling a problem? If you have continuous bubbling in the water seal chamber, then you have an air leak in the system. So first, you will check your connection sites, then you will call the doctor. The physician may have you clamp the chest tube to determine the location of the air leak. But never ever clamp a chest tube without a doctor's order. Even then, you will only do so for a few seconds and never leave the client if you've clamped the chest tube. Clamping is dangerous. It can lead to a tension pneumothorax. Now, chest tube removal. When the doctor removes the chest tube, the client will need to take a deep breath and hold, or Valsalva, and a petroleum dressing with a 4x4 will be placed over the site. So let's look at some conditions associated with chest trauma. First, hemothorax and pneumothorax. Let's look at the patho. This is when blood or air has accumulated in the pleural space. So what's happened to the lung? It's collapsed. So, what signs and symptoms do you expect? Will this client be short of breath? Yes. Will their heart rate increase? Yes, they will have tachycardia. What will you expect to hear when you listen to their chest? Diminished breath sounds. You're going to hear diminished breath sounds on the affected side. And when you observe the chest rise and fall with breathing, you will see less movement on the affected side, less movement. Could this client have chest pain and a cough? Sure. And these symptoms will of course be worse depending on the size of the pneumothorax or hemothorax. Now, what's going to show up on the chest x-ray? Air or blood. Air or blood. You will see air or fluid in that pleural space. Now look at me for a second. Let's talk about something that you may see in a client with chest trauma called subcutaneous emphysema. Subcutaneous emphysema. That is when air is trapped in the subcutaneous tissue, usually in the neck, face, or chest. It has a characteristic crackling feel to the touch. It's a sensation that's described as similar to touching Rice Krispies, and it will probably concern your client, but it will usually be reabsorbed by the body. Now, one more thing. If you have someone that walks in, let's say they have a machete sticking out of their side, what do? Leave it alone, right? Yes, we leave it alone. You give them a chair to sit in. In fact, they can have 2 chairs if they have a machete sticking out of their side, okay? But you do not pull out the penetrating object. What if a little boy is playing on the playground? He falls on a pencil and the pencil stabs into his heart. Do you remove the pencil? No, you leave it in there, because if you remove the pencil, the child could hemorrhage to death. Let's pretend that I throw some Charms Blow Pops out to all of y'all, okay? And then a watermelon one just sticks in someone's eye. Do you say, ooh, watermelon, and pull it out? No. Okay, what should you do? Leave it alone, okay? You leave it alone and we'll take them to the hospital like that. In fact, what we will do is we will grab somebody's cup, make sure it's clean as possible, cover the eye with the cup so that way they can't move the eye at all. We don't want any more trauma. What should they do with the other eye? Cover it as well, because if this eye moves, this one's supposed to move too, right? And we don't want any movement. So they're going to have 2 cups over their eyes, and we're going to transport them to the hospital like that. They're going to look like an idiot, but at this point they don't care. They've got a blow pop in their eye, all right? So again, never pull out a penetrating object. Now back to treatment. The client may require a thoracentesis, chest tubes, daily chest x-ray. These things are all done as part of treatment for hemothorax and pneumothorax. Now, if a pneumothorax is present and the client has a chest tube, what type of bubbling would you expect to see in the water seal chamber? Intermittent bubbling, yes. When the air from the pleural space hits the water, you're going to see bubbling. I'm just making sure that y'all all got that straight. Now, let's talk about attention pneumothorax. Attention pneumothorax can be due to trauma or too much PEEP, positive end expiratory pressure that is set on the ventilator, or from clamping a chest tube or taping down an open pneumothorax on all 4 sides without the air valve. Okay, tension pneumothorax is the one you don't want. You just want a plain pneumothorax, okay, if you can pick. You don't want the tension pneumothorax because of the word pressure. All right, so let's look at that patho. Pressure has built up in the chest or the pleural space and has collapsed the lung. And pressure pushes everything to the opposite side. We call that a mediastinal shift. Everybody knows your trachea is not supposed to be over here, right? Right, that's bad, okay? So let's look at some signs and symptoms. Subacute air or emphysema, absence of breath sounds on the affected side, asymmetry of the thorax. Okay, again, the trachea will be off-center depending on which side the pressure is coming from. The client may be in respiratory distress, and this is a medical emergency, and it can be fatal because the accumulating pressure compresses those vessels, which decreases venous return and, of course, decreases cardiac output. Treatment. Think about it. In a tension pneumothorax, both your heart and your lungs are compromised, so we've got to get that air out. The physician's going to go ahead and insert a large bore needle placed in the second intercostal space to allow excess air to escape. Then the physician will find the cause and chest tubes will be inserted. Next is an open pneumothorax. Let's look at this patho. This is where there's an opening into the chest that is large enough that allows air into the pleural space. It allows air into the pleural space. Sometimes we call this a sucking chest wound. We'll see this with a gunshot or stabbing victim. Now again, are you going to pull out the knife? No. Okay, I think we've all got that straight. We're not going to pull out the knife. Here's the deal. This is what we do. You have the client inhale and hold, or Valsalva. Now you can't just tell somebody, Valsalva for me, Papa. He doesn't know what you're talking about, okay? So I like to tell them to take a deep breath and hold, or hum. That works very well. Both of those will increase the intrathoracic pressure so no more outside air can get into the body. Then we're going to place a petroleum gauze over the area and tape down how many sides? 3 sides. We're leaving that 4th side open so that it can act like a what? Air vent or flutter valve. An air vent or flutter valve, as it is sometimes called. Now think about that. You've got the sterile Vaseline gauze over the site, tape down 3 sides, because we told you to leave the 4th side open so that it can act like an air vent or flutter valve, because if there's some air in there that's trying to get out, don't you want it to be able to? Yes, you don't want to trap air inside, because didn't we say that could lead to a tension pneumothorax? Yes. Now, we want them to sit up to assist in lung expansion, but if you're talking about a trauma client, be sure to evaluate their other injuries before you just sit them up. Now let's look at fracture of ribs and sternum. This is one of the most common injuries you will see from chest trauma. This is the steering wheel injury. Signs and symptoms: pain, tenderness. The client will naturally splint that side by supporting with their hands and taking shallow breaths to try to decrease the pain. You might see crepitus. This is when the bone ends are grating together. The client may have shallow respirations, and if you have broken ribs and shallow respirations, which acid-base imbalance are you headed towards? Respiratory acidosis. So treatment, we're going to give a non-narcotic analgesic because we do not want to suppress the breathing even more, do we? No. That would just make problems worse. We want them to deep breathe, so we're going to have to relieve the pain to get them to cooperate. They may even require a nerve block by anesthesia to assist with productive coughing. The nurse may help to support the injured area with the hands and assist in deep breathing and coughing. Immobilizing the chest with binders and straps is not recommended because it leads to shallow breathing, atelectasis, and pneumonia. You're going to have to observe for other complications such as pneumothorax, hemothorax, and flail chest. Now let's look at flail chest. That's when you have multiple rib fractures. Signs and symptoms, well, I guess they're going to have some pain. And since the chest wall is unstable, you have what is called paradoxical chest wall movement in the affected area. The affected part of the chest sucks inwardly on inspiration and puffs out on expiration. That's not normal, okay? A normal healthy chest area expands on inspiration and the flail section is going to suck in, and just the opposite on expiration. So now when the client breathes, the normal chest goes one way and the flail section goes another way. It looks like a seesaw movement. You and I like for people to breathe nice and equal, and we like for their chest to rise and fall how? Symmetrically. So to assess chest symmetry, you're going to stand at the foot of the bed and observe how the chest is rising and falling. Now let's look at more signs and symptoms. Dyspnea, cyanosis. Clients will also have an increased pulse. Now let's look at treatment. We're going to stabilize the area. We may intubate, ventilate, or use positive pressure ventilation to stabilize the area. These clients will usually be placed on the ventilator with PEEP, positive end expiratory pressure. Now when somebody's on PEEP, they're on the ventilator. So let's look at how this works. On end expiration, the ventilator is going to exert pressure down into the lungs to keep those alveoli open. And that's good because that's going to improve gas exchange and it decreases the work of breathing for the client. Improves gas exchange and decreases work of breathing. Anytime somebody's on PEEP, you are putting pressure down into the thorax, aren't you? So what happens to the chest wall? It expands and it realigns the ribs so they can start growing back together. It expands and realigns the ribs. PEEP may also be used to treat pulmonary edema and severe hypoxemia. The classic reason to use PEEP is for treating ARDS. Now, while we're on PEEP, I do want to mention BiPAP and CPAP. We've talked about the client who is intubated and receiving PEEP. That's an invasive procedure, right? Right, because we're intubating them. But we are also able to provide positive pressure ventilation through nasal or face mask, and this is called non-invasive positive pressure ventilation. BiPAP and CPAP are two forms of this non-invasive way to apply pressure into the lungs. So let's look at BiPAP. BiPAP stands for bi-level positive airway pressure. This is used with acute respiratory failure in clients with COPD, heart failure, sleep apnea. It may be used when we're weaning a client from the ventilator. Again, it's called bi-level because it exerts different levels of positive pressure support along with oxygen. This client must be able to breathe spontaneously and they have to be able to cooperate with this support. Now let's take a look at CPAP. That stands for continuous positive airway pressure. And again, the name says it all. This delivers continuous pressure during inspiration and expiration. This is most commonly used for obstructive sleep apnea. Now, whether you have a client who's on PEEP, BiPAP, CPAP, what's going to be your priority nursing assessment for these clients? Bilateral lung sounds. Yes, you've got to be checking those bilateral lung sounds every 2 hours. Think about that. With any of those, BiPAP, CPAP, PEEP that we mentioned, we're putting pressure into the thorax. So could you pop a lung? Yes, that's what we're scared of. We're scared of a pneumothorax. So let's do a quickie critical thinking exercise. Let's say you have a client that has COPD. And we all know you never give too much oxygen to a COPD client or they will stop breathing. Yes, it knocks out their drive to breathe. So let's say that you have a COPD client and they're coding. Tell your friend how much oxygen you're going to bag this client with. 2 liters or 100%? Tell your friend. Okay? How many of you wanted to give them 2 liters? How many of you wanted to give them 100% oxygen? Now, I know what some of y'all are thinking, okay? If I give this client 100% oxygen, they're going to stop breathing. Well, y'all, if they're coding, are they breathing? No, okay? Rule, never withhold oxygen from a dead or dying person, okay? That will always be wrong. So we do give 100% oxygen to a coding client, even if they have COPD. All right, now let's look at pulmonary embolus. Causes, this can occur if a client is dehydrated, has venous stasis from prolonged immobility or surgery, has been taking birth control pills, or has clotting disorders, or heart arrhythmias like atrial fibrillation because you can get blood stasis in the atria if they're not pumping correctly. All of these things make your blood thick. So a thrombus forms, it dislodges, and it goes to the lungs. 95% of them come from the deep veins of the legs. Let's talk about what's happening in the lungs when a client has a pulmonary embolism. If there are a bunch of clots or roadblocks out in the lungs, can blood get through that area? No. So blood backs up behind the clots and the volume is increasing in that area. What did we say? More volume, more pressure. Yes. So the blood pressure is going up in the lungs. Are you supposed to have high blood pressure in your lungs? No. And what's the name for high blood pressure in your lungs? Pulmonary hypertension. So which side of the heart is going to be affected? Remember back in cardiac? The right side. Yes, the right side is going to be affected. The right ventricle is going to have to pump against that hypertension. So could you get right-sided heart failure? Yes, and what's the fancy name for right-sided heart failure? Cor pulmonale. So you've got to be watching those right atrial pressures, right? How do we do that? CVP. Since there is poor oxygen exchange in the area blocked by the clot, the client's going to be hypoxic. That's bad, isn't it? Yes. We said the client's becoming hypoxic because they have a clot in the lungs. So what has happened to the PO2 on the ABG? It's going to be high or low? Low. It's going to be low. So let's look at some signs and symptoms. The number one symptom is hypoxemia. If you have a clot in your lungs, what's going to happen to your PO2? It's going to go down. Yes, this is the person you can give 100% O2 to, and they can't get their PO2 up because there's a clot in the way. The oxygen cannot get where it needs to go. So the client will be short of breath. They may cough, have an increased respiratory rate, increased D-dimer. D-dimer is increased with pulmonary embolus. A D-dimer is a blood test. It will tell if there is a clot located anywhere in the body, not just the lungs, anywhere in the body. A positive VQ scan, a ventilation perfusion scan, can detect an embolus, and that's usually done in radiology. This is going to look at blood flow to the lungs, and dye is used. But you have to make sure that you remove the jewelry from the chest area because that will give false results. So remove that jewelry. A VQ scan is the most widely used diagnostic test for this, but if it is inconclusive, you may also see a spiral CT or a CT angiography ordered. Now let's do an NCLEX critical thinking exercise. Let's say a D-dimer has been ordered because a PE is suspected in your post-op client. Now I want you to ask your friend, how do you know that this test will come back positive? Ask your friend. Think hard. Here's the deal, y'all. Isn't your post-op client supposed to have clots? Yes, if your client is post-op, you want them to have clots all over that incision site. Otherwise, they're doing what? Hemorrhaging, all right? So, a better test to diagnose a PE when a client is also post-op would be a VQ scan. That's an X-ray test. It takes pictures of the blood through the veins in a certain area. Let's look at other signs and symptoms. What is hemoptysis? Coughing up blood. Coughing up blood. If you had a clot in your lungs, what do you think is going to happen to your pulse? It's going to increase because you're hypoxic. Chest pains can occur. Now this pain is not like somebody who's having an MI, a heart attack, okay? This is going to be sharp stabbing pain. The chest x-ray is going to show atelectasis. Blood pressure in the lungs is going to go up. Remember, pulmonary hypertension. When you have high blood pressure in the lungs, what just happened to the workload on the right side of that heart? It increased, yes. So increased workload on the right side of the heart. So now I'm at risk for right-sided heart failure, yes. Treatment. We prevent when we can, and we prevent by ambulating and hydrating. We ambulate and we hydrate. We're going to give this client oxygen, of course, according to their ABGs. We're going to decrease pain. They're probably going to be placed on heparin, Coumadin, Lovenox because we want to decrease that clotting. So let's close with an NCLEX question. Can you be on heparin and Coumadin at the same time? Ask your friend. Yes, you can be on heparin and Coumadin at the same time because as they taper down the heparin, they will start increasing your PO Coumadin. Anytime we start somebody on heparin in the hospital, they're probably going home on Coumadin. So we taper off the heparin as we add in the Coumadin. And that's all for respiratory.